Absolutely. Good morning. Good to see you.
It's so casual.
That's right. Breakfast is out and ready when you are.
I'm mostly concerned about the coffee.
I got to tell you today.
I told them that people stay home enough.
Good morning. How's everybody doing?
Good.
How about that weather this morning? Wasn't it beautiful?
Bring it on.
All right. So Chris Neal's going to do our invocation. Chris?
Not going to throw anyone under the bus by name. I was just tapped on the shoulder and said, "Can you pitch it on an invocation?" So this is unprepared. So it really just something I thought I would say, because this is the first time I've been here since we got to Starman. I missed the last couple of weeks, but just about the power of community. And we brought our office back on June 1st, except for a couple of exceptions. The group is finally growing here. And just a thought I would share is that we as creatures, as human beings, really are meant to live in community. We thrive in community. When we're isolated, we tend to get in our own heads and evolve. So if we can bow our heads real quick, I'll say just a quick prayer. Dear Heavenly Father, thank you for community. Thank you for work, for good people. Thank you for purpose. Please continue to touch our lives, that we would seek to touch others. In Jesus' name we pray. Amen.
Stand for the pledge.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
The things we think, say, and do.
Is it true? Is it fair, all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Thank you, Chris. You see why I passed that last second volunteer. Chris, in a volunteer organization, if you want to keep getting tapped on the shoulder, do a good job. Brad, you have our Sergeant at Arms report.
Yeah, we got a good group today. I can barely keep up. So thanks to Steve, wherever Steve went, for helping. There's Steve. We have 32 members here this morning. We have 2 guests. So, Guy, you have a guest?
John, stand up. So this is my friend John Van Kemp, who works with Accenture, little software company with like over 500,000 people. So John has expressed some interest in Rotary, so I thought I'd bring him to breakfast this morning.
And Matthew, you have a guest.
Yeah, good morning, everybody. My better 3/4 is my wife, Mark.
Rick, you have our birthdays and anniversaries.
I'll tell you what, we have a short list of club anniversaries, shorter list of member birthdays. Short of some partner birthdays. However, we do have wedding anniversary, so it might not be a good day to be born, your partner to have a birthday, or even join the club. It's a great time to have a wedding. So, this week, I know that Dale Farlow here, this is, oh my God, right here. Dale, you guys had one Tuesday? 15th? Yeah. Oh my God. This Christian pray back to New York City. Yeah, and I think you and Phil had one also on Tuesday. Yeah. How many? 36. Good job, good job, good job. Yeah. Really? Somewhere, Dr. Walt, there he is, right there. And man, it must be a good day to get married on June 15th, because we got about to load up. Walt, you and Laura? Yeah, that was the drug conflict with that, so. Same day as well. Tell me how many of you got? 36. 36. Wow. You just buy me a double wedding or something. Yeah, there you go. 2 for 1. All right, and for next week, heads up, Jim Kennedy, Jonathan Smith, Mike Conrad, you guys are up next week. Don't forget, 4 more. All right, and that is it.
Thank you, Rick. So apparently 36 years ago on this day, the world became safer. Couple quick announcements. This is our last breakfast meeting of the Rotary year. So in case I seem like I'm smiling extra big. And June 24th, which is next Thursday, a week from today, is our district installation. So I don't know if you signed up. Mike Conrad's been working really hard on it. Chris Justice is going to be our incoming district governor. So please come out and support Chris and Mike. It's going to be at Grandover. So that's it. Any announcements on Victory Junction, Matthew? Okay. We'll keep working on it. Chris Neal, you had an announcement on membership.
Y'all might have noticed last Friday, 7-day letter went out on Scotty Seaver, who has put in her application for the Sunset Club. Thinks she'll be a great member, a great fit. This is actually a little bit of a formality because she's been going to the Satellite Club meetings for several months now. So we'll make it official and start building.
Nice. Best way to do it. So guys, on the membership note, we do need to recruit for this club. You know, it's been a tough year with having guests. It's nice to be able to invite some guests back to come join us for breakfast. So if there's somebody out there that wants to work on who they are, not what they have, please invite them to join our club and come and enjoy breakfast with us. So that's all we have for club announcements. Buster, you want to do our happy dollars,
baby? Whoa.
Is that what we're going to get?
My 4 boys got an opportunity to go visit. I have an aunt that lives in Berkeley, and my uncle who just turned 90 lives in Eureka. So the 4 boys are riding around in a little sedan, jammed up, going all through California. They're able to go from San Francisco all the way up the coast, along to Eureka, go to Mount Shasta, and now they're currently in Yosemite for a few days. Yeah, an epic day trip. No parents involved.
So I graduated this morning. Steve brought in my white badge. So celebrate that.
Did nobody bring the forward?
We really got slack.
I got 20 happy dollars. One, as secretary of the club, I am so overjoyed to see so many of you back with us. And this is a great club, and you make it that way. And the other was for being remiss in carrying around Brad's badge in my computer bag for that long.
All right, you got to rest. Tired of that, Chip.
I got one. Go on, follow me, Buster. I got one. Last Saturday, a friend of mine and I, Allison, we visited here, and Steve and Peter went off to the Art and Bloom flower show at the North Carolina State Museum of Art. And thank God they serve cocktails when you walk in the door. But Peter, who is in the Sunset Club, is a flower buyer from Freshwater, and you could not have had a better private guy for the whole show. It was a fantastic time. So we had a lot of fun. But 2 days ago at 1:30 or 12:30, one father popped into the house in Yale, and he moved in, and he would be here this morning, but he had an 8:30 interview with a guy that he really wants to work for out of New York. And last night he was interviewing with somebody from Australia from 6 until 7 last night. So anyway, sooner or later I'm gonna be able to say, I think you got a job. It's kind of very
Yeah, I'll throw one up there.
Oh, and you.
I'll Venmo, I don't have cash. So I've had some scheduling challenges this year, and it was really tough for Mylan and I, school, and I told him, I said, you know, buddy, if you can just get through school and get a B in Chinese. So if anyone has their kids in language, you know how challenging it is, and you got to be Chinese.
And they get really tired. Well, Grandpappy and one of his buddies, they were sitting around watching the Westminster Kennel Club show after a few of the dog food commercials. Buddy turned to him and said, Grandpappy, what kind of food do you feed your dog? Grandpappy said, I don't know, just regular dog food. He said, why, what do you feed yours? He said, collars. I said, man, my dog would never eat collars. He said, yeah, mine wouldn't either for about a month.
So I'm really excited to be able to introduce our speaker for the morning. Rick Crow and I worked very closely together about 15 months ago. We had the opportunity to be called upon and stand up the COVID Command Center at Cone Health. And literally, we were across from each other, and we just struck up conversation. And in my mind, I thought he would make a great Rotarian. But he's such a stellar guy. And in follow-up to the presentation we had last week, I thought, you know, knowing how he is with data and numbers, it would be a wonderful opportunity for you guys to hear some of the reports that we get out of the hospital. So I'll turn it over to Rick.
I'm not as good just standing at the podium. So you're touching on some things near and dear to me. I spent 4 years in Berkeley. Years ago, I have a daughter that lives in Australia. And this subject is you know, it always strikes close to home. I'm sure it has for everybody in here. I just learned yesterday morning. I had a friend that I grew up with from the time we were very little that passed away from COVID just yesterday, and very quickly. So you know, depends on how, you know, what the underlying issues are as well. But what I would like to do today is just sort of summarize what we did in following the progression of COVID through this region, and then really focus a little bit more on where we are today, the state of vaccinations, and what that means for us going forward. And I guess this is a bit of a follow-on to a previous speaker that you had here. Look right there. Okay, so this is what hospitalizations at Cone Health look like through the pandemic. And you can see here around July of last year, we hit a peak, and that was a peak everybody was hoping for, because we thought once we get past that peak,
we're good to go. At least many people throughout the country thought that. And that's what that dotted red line represents, is what a lot of folks thought was going to happen once we hit that peak. However, what you can see, and what they thought is maybe we had this big dip and then maybe a little bit of a surge again as you got into flu season. But what actually happened is that we only dropped a little bit after July, and that's because of a variety of factors. People were going back to school, especially the college kids. We had some holidays throughout the fall and into the winter. Travel picked up again, and we know that because we monitor things like the number of TSA reviews that go on. That information is available publicly. People were indoors again, where it's easier to spread the disease. And so by January, all the hospitals across the state were very concerned that we were going to exceed capacity. And you probably saw stories hitting the news at that point. I was on one of them. Many people at Cone Health were, where we were really encouraging people, look, masks, socially distance, all of those things, so that we can get this under control, because obviously we're going to treat COVID patients. But if you had an elective surgery to repair your hip or something like that, chances are you weren't going to get that anytime soon, because there just wouldn't be room in the hospital. So that's sort of the progression through this past January. Sorry, I've been in so many of these where someone else is driving the slides. And by the way, I'm really happy to be here, even though it was 7 o'clock in the morning, because Danielle told me there were real live people in the room. And I've spent the last 15 months on nothing but Zoom and WebEx calls from morning till night. So thanks for having me here. So one of the things that we wanted to try to do was help to mitigate the spread of the disease, and we used analytics to do that. And one of the more interesting things that we did was to try to predict where the disease might pop up next. And then we fed information to the health department and others, including our own mobile health people, to get out there and start testing people, and if you find positives, start to isolate them and that sort of thing. So one of the really interesting ones that we found is in the upper right-hand corner there. That population is largely the Vietnamese Montagnard folks. Now, if you know anything about the Montagnards, they're a mountain people in Vietnam. They're heavily persecuted in Vietnam. And what you may not know is Greensboro has the second largest population of Montagnards outside of Vietnam. And they tend to live communally. They share a language, a culture, etc. And so they live in apartment buildings, extended families crowded inside one apartment, that sort of thing. Perfect conditions for spreading a disease like COVID. Well, we actually developed something that, and I would also mention that they work in places like meat packing plants, where they work with a lot of folks from the Latin community. And so there's this intersection of cultures that goes on in environments like that. So what we actually did was something that I'm not aware of anyone else in the country doing. I have a really brilliant data scientist on my team who developed, you've probably heard of contact tracing. Normally that's a very manual process where you find out someone's COVID positive, you send people out from the health department, they interview them, try to figure out all the people they've been in contact with, and it's a long manual process to try to track those people down and get them tested. But one of our folks developed a way of using network analysis and what we know about all the people that we treat from Cone Health, to actually in the upper left-hand corner, visualize the network that somebody that was positive had. And then we were able to use that with our community health folks in the health department to tell them, hey, you need to go out to this apartment complex in Northeast Greensboro. It looks like we're about to have an outbreak among the Montagnard community. We have a couple of positives. If we don't get out in front of it, we're going to have a big cluster of positives there. And so they went out there, proactively did the testing, were able to quarantine the positive folks that they found, and it really prevented a much larger event among that population, which likely would have spread into the Latin population as well because of the common working environment. So what we've learned as we went through this was that you heard a lot of talk about the hospitalizations, but what I heard was, it was sort of just lump hospitalization together. But what we did was slice and dice the data, and one of the things that came out of that data was that 2/3 of all the hospitalizations for COVID were people 65 and up in the Cone Health facilities. And more than 80% were age 50 and up. Now, at this time, remember, we're at risk of running out of capacity at the hospital. And the first phase of vaccinations had started, and the CDC guidance for that was vaccinate healthcare workers. And so all across the country, that's who was being vaccinated. And we were all waiting for later phases to come in, including the governor in North Carolina and the Secretary of Health and Human Services. Well, through our analysis, we uncovered that, if we can do something to bring down hospitalization rates among the elderly, we're going to free up a ton of capacity within the Cone Health hospitals and keep many of those folks out of the hospital. So we actually made that recommendation through Terry Aiken, our CEO who just retired, up through the state government. And it was actually a few days later, acting on that information, that Governor Cooper decided to step ahead of the CDC guidance, which at that time was still vaccinate healthcare workers, and say that we could now go forward and start vaccinating the elderly, age 65 plus. I hate to call that elderly because I'm not that far away from there. And I don't feel elderly yet. So anyway, the governor made that recommendation. And as you can see here, I mean, this is January, where the previous curve that I showed cut off. And hospitalizations just plummeted as soon as we started vaccinating the elderly. So rather than taking the approach of just healthcare workers, and rather than taking sort of a general approach to the population, we were actually able to point to subsets of the population. And in fact, that wasn't the only subset that we pointed to. There were other factors within the elderly population that we could identify as high risk and that we should prioritize for vaccination. And that really is what saved the day across the state as far as exceeding capacity for hospitals. So where are we now with respect to vaccination? Well, you may have heard President Biden the other day said that there's a goal of vaccinating 70% of the population by sometime in July 4th. The 4th? Yeah. Well, we're not anywhere close to that in this region, nor in North Carolina. We have topped out at between 45 and 50% here, and we are relatively flat. There's pretty significant uptake in vaccinations early on, but that has very much flattened out. In fact, there are vaccination sites that close because people just weren't coming. And so at best, we're projecting that we might hit 70%. Well, not even 70%, but just under 70%, maybe by late October or into November. But that's if things actually pick up a little bit from where they've been. If they stay as flat as they've been, yes.
Is this fully vaccinated or even one vaccine in the case of two vaccines?
This is, this one actually is including anyone even with one vaccination. So this is total vaccination. And you'll see a little bit more of that in another slide. So we have a long way to go here in terms of getting to 70%, simply because as COVID has seemed to tail off, people are feeling a lot safer. And if they have any questions or concerns about being vaccinated, they're not coming. And so we have to do a job of getting out there, getting the word out there, helping people to understand the vaccine, hear their concerns about it, address those concerns. And I'll explain why that's important. So here, I should point out as well, this is the data that comes from, that is reported to the state's DHHS. And we show that here because Cone Health only provides a portion of the vaccinations in this region. We don't provide them all. So this right here reflects them all. Now, if you look at what Cone Health has done, we have given first and second doses to about 90,000 people. And we have another 92,000 that have had first doses. We have 92,000 that had first doses, 88,000 of those have had first and second doses. So we've got about 2,400 in the queue waiting on their second dose as of yesterday. And you can see most of that's been the Pfizer vaccine. It's very important, given our culture at Cone Health, to appreciate the diversity in the community as well. And so you may have seen in the news that Cone Health designated 35% of its vaccines for the goal of getting those into underserved community arms. Most of those are Black or brown arms. And we've actually hit that goal. And what's interesting is with the focus on 65 plus, the 65 plus population here is not 35% African American, for example, as it is on average. It's actually much lower than that. And people speculate why that is. Is it because of the poorer health of the African American community and their lifespans are lower? We know that's true in this area. They can be lower by 10 to 12 years. However, there are also factors like a lot of people from the north who are white, retired, they retire here. And so they come into this area and sort of dilute the population and drive that number down. So we can't give causation for why that is lower. That's a different conversation. But you can see that here are the vaccinations by date, and now here we are. And you can see how rapidly this has fallen off. So people just aren't coming in to receive vaccinations now. And that's likely to be a problem as we move into the fall. This gets a little bit more into what I was talking about before. SVI is the Social Vulnerability Index. It's a standard index that's used at the national level. And the shadings here show you what the social vulnerability is for different census tracts in our area. And you can see here on the right, the darker orange it is, the more socially vulnerable the population in that area is. And that's a combination of 17 different factors that make you socially vulnerable. And so that, that includes income, education, housing, transportation. 17 variables factor into that calculation. You can see we have somewhere between 25 and 50% vaccination across a lot of these areas, which is, it's good that it's consistent, but it's only 25 to 50%, which is why we're sort of stuck where we are at around, just below 50% for the region. So what does this all mean for later on? Well, the reproduction number that we talked about right here, that says if I'm infected, how many people on average would I infect if they come into contact? So the basic reproduction number for our region is about 3 right now. So if you look at immunity from vaccinations, that's the yellow line coming across here. Now, we also know people have had COVID and recovered, or they have some other reason for natural immunity. So either recovered immunity or natural immunity. If we estimate what we think that is in the population, that's between the two dotted horizontal lines up there. It adds on to the vaccinated immunity and brings us up there. So that yellow box up there represents about where we think we are right now. Now, in order to get to herd immunity, you've got to be at or above that teal line, that teal curve. So we, with a reproduction number of 3, we could still be a bit below that, or we could be a bit above that. The problem is, if this reproduction number starts going up again, then we move further up that teal curve, and the more people you have to have vaccinated in order to get herd immunity in the region. And so we are sort of teetering on the brink. We're sitting right on the fence as far as safety from having a significant recurrence of COVID going forward. That is the main reason why people are pushing for more of the community to be vaccinated.
Isn't it true that you're, in general, communities try the carrot approach? Do you ever foresee when you use the stick approach? Because I would suggest that those folks are at risk to the rest of the community. And I don't mean that sounds like a community, yeah, but at some point, the mindset, I think, has to change a little bit, that these folks are at risk. Yeah, I mean, it's gonna increase healthcare costs, hospitalization.
Right.
You know, so I understand the data privacy, but is there ever a thought to make, we know who's vaccinated, but naturally you have to say demographics or some kind of identifying communities that aren't.
Yeah.
Folks that are involved in getting them. I mean it in a positive way.
Yeah.
I don't want to sound big brother here, but at some point, the mindset has to be slightly different.
Well, it's a great segue into my next
Oh,
slide.
I'm sorry.
No,
And then
it's perfect.
I know, I'm contact tracing, I work
Yeah.
at a company that does federal government.
Yeah.
And we used, with the approval of the data privacy for the federal government, we used GPS and all kinds of. So as soon as we knew we had it, we just knew where they were. And we used
Right.
it. Is that how your app works as well?
Yeah, we use many data sources.
Right.
Some go down to the individual level, some
Sure.
are population level, like, you know, the TSA travel data and some other local travel data. And yeah, so we use a wide variety of that sort of data all together. So this is getting to what you were just talking about. There's been a national study that polled people, survey and polled people about their interest in getting the vaccination. One of the problems that we have, anybody has anywhere in the country, is you'll have populations that have access difficulties. That could be that they don't have a car. It takes them 3 buses to get to a vaccination site because there's no vaccination site near where they live. In Southeast Greensboro, we have a lot of those challenges with healthcare generally. And so they don't have local access to the vaccination sites. They have difficulty getting to where they can get a vaccination. And yet there are quite a few folks who are willing and interested in getting the vaccine. So we were actually able to take the results from the national study and apply the characteristics that they identified to our local population. And what you see here are areas, this is just a portion of the analysis, but these are areas where we've identified that there's likely a high percentage, you can see, you know, between 1,000 and 4,000 people in one census tract, which is not a large region, that we believe are interested in a vaccination, but haven't shown up to get one yet, probably because of these other barriers. And so we are doing exactly what you suggest, which is to use this information now and hand this to our community health folks with our mobile vans and things like that to get out there and to do campaigns through the places where people are going to hear about it, like their local church, to say, hey, there's going to be a vaccination van here in the church parking lot on Tuesday. If you're interested, come on down, it's free. You know, and so we're trying to use these kinds of analyses to find people that we think want the vaccine, because we know there are a lot of people that want it but can't get to it. And before you use an even bigger stick to start trying to persuade people who feel like they don't want it to have to get it. Let's at least find the ones that want it and help them to be vaccinated. So there's a lot of analytics, it's sort of a summary level. There's a lot of predictive modeling and so on that goes into this process to arrive at this level of information that becomes actionable for us as a healthcare provider. So, where are we? It would be very easy to let our guard down now because things seem like they're getting back relatively to normal. But the problem is that this is actually a time of year when you would expect things to be a little better. And if we keep in mind where we are here in this graphic, as far as total vaccinations versus where we need to be in terms of herd immunity in the area, we still have a significant threat of a resurgence. And the reason is that infectious disease, and I would point out also, brag on my team a little bit, we've had, I think, the best performing predictive model in terms of where COVID is going that I've seen anywhere. In fact, so much so that one of the data scientists on my team that really led that effort and built that model has the London School of Medicine actually reached out to him and has put them on their advisory committee evaluating the COVID work from all over the world. So, that's pretty good for a mid-sized health system sitting in the middle of North Carolina to have had results that are that good that it's drawing that kind of international attention. So, and in fact, I'll go back here just to show you this. These red dots are actual hospitalizations. This black line in between is what he predicted they would be back here. So, quite a good model, so, when you're trying to model that, you need to know 4 things. How many people out there are still susceptible? How many people have been exposed? How many people are infected currently? And how many people have recovered or have some other immunity, whether vaccine-driven or natural immunity? That's the biggest unknown. We do not know how many people have recovered and how many people may have immunity. We know how many have been vaccinated. We know how many we've seen, but many of these cases were asymptomatic or mildly symptomatic. So we really don't know that very well. That's why there was that box on the earlier slide talking about herd immunity.
What assumptions are you making about the lifespan of the vaccines? That they'll last 12 months, 18 months?
Yeah, so we have different scenarios that we model.
Right, because no one knows that.
Right, so we have a basic model that just assumes once recovered, you're immune.
That's it.
Like you were. So that's the
So it's not like
the
the
basic
vaccine
model.
where you have to do it again.
Well, that's the basic model. But we
Okay.
have versions where we assume different lengths of immunity.
Right.
And so that gives us a window of what we think may happen. What we do know is, we follow the reports that come out every few months. There's another report that says, well, okay, now we've added 3 more months following people that have been vaccinated. And so far, it looks like it's, immunity is good for 6 months. And the next report will probably be immunity is good for 9 months. Or they'll find that, okay, well, 6 months was good, but around 7.5 months, it tailed off, something like that. But there are encouraging studies. A study out of Britain recently that where they looked not just at immunity in the serum, but they looked in the bone marrow. And what they found is that the cells that produce the antibodies were still much more active in the bone marrow than they were circulating in the blood. So the body was retaining that ability to generate antibodies much more so than people thought just by looking at serum antibody levels. So anyway, knowing that those are the things you have to know, many people are still susceptible. We know that about 55% of the folks in this area are still susceptible, except we don't know how many of those may have had mild cases and recovered, right? The immunity period is unknown, so we have to make some assumptions about that. So it could be that people were immune, now they become susceptible again. Resurgence is likely in the fall because we're seeing some variants around. We don't think the variants are worse than what we've seen, but they are different. And it's yet to be determined what that difference means in terms of susceptibility. Seasonality, again, as we move later into the year, we'll go indoors where it's drier and in closer proximity. And, we're all relaxing restrictions. We're here in the room today, not masked and all of that. And that may be okay now, but, as we move further into the year and other conditions make it more likely for COVID to spread, and that could be an issue again. And then other respiratory viruses will be back in play. And we're strongly encouraging people to get flu shots. One of the difficulties with flu is the presentation is almost identical to the presentation from COVID, except for with COVID, people tend to report shortness of breath sooner. And so what that means is that if people get the flu and COVID circulating, that increases the risk of overwhelming hospitals again, because you've got to get the people into the hospital, test them for the flu, test them for COVID, make the diagnosis. And so this past year with all the masking, we started, last summer when it was winter in the Southern Hemisphere, we started looking at the occurrence of flu in the Southern Hemisphere. And what we found is that down there, flu was virtually non-existent. Now, flu is never as big an issue in the Southern Hemisphere as it is in the Northern Hemisphere, but it was virtually non-existent. And that, those countries at that time were using COVID protocols. They were masking and distancing, trying to avoid COVID. And so we thought there was a possibility that would happen here. Americans, maybe a little less likely to be compliant with some of those edicts that come from above. So we weren't really sure whether we would see the same magnitude of effect, but in fact we did. There was virtually no flu in the United States this past year. I mean by more than an order of magnitude. It's like 100 times less flu than you would normally see. So if we were still heavily masking, we'd probably see that effect again later this year. But since we're relaxing restrictions, chances are we'll have more flu again, and there will be people getting COVID as well because they're susceptible. And so that could make for a bit of a tangled mess later in the year. So, expect us to be coming out with messaging, especially as we move through the year, that is encouraging people, hey, mask, distance, the risk for COVID increases just because of the time of the year, the number of people still susceptible out there in the population. Unless something happens where enough people start coming back to the vaccine that we get up to that herd immunity level. But for right now, that looks pretty challenging. So that's it for me.
You coordinate directly with the pharmaceuticals because you have an excellent team of selling analysts. You share that to say other hospitals in other countries and the pharmaceuticals.
Yeah, and this is just scratching the surface with what we've done. And yes, as far as COVID goes, we've sort of treated that as a public, what it is, public health issue. And so we've not held back or reserved any of what we've done here. Anyone who is interested. In fact, we have a public-facing site that is up there on one of the links where you can go out every day and see the current stage of our analysis of COVID in the region. Yes.
So I just did a little research here last week. There were 100 cases that we got some more in 2019, 2020, 27 reported flu deaths. So that would go far along with what you said in the 2021 season. So given that the flu virus, the COVID virus,
Well, what I can tell you is that as we were going into that huge surge that we saw December and January, we were noticing that, and I say we were noticing, it was a result of survey data that we were bringing in from various sources, that the interest in masking and distancing was falling off, even though the state hadn't said, okay, you can stop masking, you can stop distancing. People were having COVID fatigue, right? And they were just getting together, and we noticed the effects of that. And we started a campaign going out there, really emphasizing, hey, and it was really from the standpoint of, hey, you're not going to be able to get your elective work done pretty soon because we're going to exceed capacity from all this COVID. And we saw a rapid turnaround in the survey that corresponded with a downturn in COVID. So I think COVID it's more contagious than the flu. So if one person gets it, they're spreading it, that reproductive number is bigger for COVID. So if you get one person with the flu, they're going to spread it to a fraction of a person. If you get one person with COVID, they're going to spread it to 3, 4, 5 people. So that's why you see the bigger number as long as COVID is present.
They create a much smaller number of unknown cases. People didn't have antibodies, maybe our herd immunity might be a lot overall.
I would say that's probably true in the younger population because the studies show that it was younger people who tended to be asymptomatic. So there may be a lot more younger people out there that have some level of immunity now. But for the older population, they generally have some symptoms and would then be diagnosed. So you're exactly right to the extent that the younger population has greater numbers of immunity, that would help us toward herd immunity.
Just curious, and this may be a dumb question, but with there being less flu this season, will that make the flu vaccine, is there less predictability with the flu vaccine than there might be another year?
Yeah, that's a great question. I can't say that I know the answer to that extremely well, but I think that it's a good point, and I think the answer is likely yes. It's a bit of a guessing game every year as to which strains will be most prevalent. And because flu is being suppressed around the world, we don't really have great data from other regions that would normally see it before us to know what may be coming our way. So the answer is likely yes. Yes.
I've seen this ad that Uber gives free rides. Is there a way that people in the underserved community can get the word that they're offered free rides to vaccination?
Yeah, so that's part of our strategy as we go out. Part of it's for us to go out to the community, but we also have a department that facilitates transportation for folks who are underserved and may not have access to a car or something like that. We do that for cancer treatments or other things. So yes, we have partnerships like that we can leverage to try to get people to vaccination sites.
Thank you, Rick. That was very informative. We all owe you a debt of thanks for the work that y'all did. We have one more test where if you could pick a wrap.
Sure.
All right.
The last three are 3, 5, 8. That's one of mine.
Congratulations.
Okay. Lisa, you want to pull the card? You're right. Yeah, I can say if I win, and I planned this in the very beginning, probably it's going back to the club. So if I win 100%,
Pick a winner.
it goes to the club.
Thanks for your work. It makes us all.
9 o'clock. So money's still in. It's like it's at least $500 now. So everybody have a great week. I will see you Wednesday evening next week.